Recording now? Great, thank you. Okay, so today we're going to talk about two kinds of research-based interventions that support whole health. That is, they look not only at a patient's clinical condition, but they also look at other types of supports that could help a person to be healthier or a family to be healthier. And the interventions that we're going to focus on are interventions that help survivors of domestic violence and ways to help Latino families to address a child's mental health condition. Next slide, please. Next slide, please. There we go. So one previous to that, and here we go. Thank you. Go back to, there we go. So the research that we're going to be talking about today was funded by the Patient-Centered Outcomes Research Institute. And if you are not familiar yet with the PCori, the Patient-Centered Outcomes Research Institute, here's their homepage. And it's a place that you can go to find research projects that, work about what works well for patients who face various health conditions and various health equity problems. And it's also a place that you can go to find out what new research might be funded in the future and to get funding for a project that you might be working on. So next slide, please. We used research that was funded by PCori in our recent paper, Opportunities for Whole Health Promotion, Research and Examples. And I want to gratefully acknowledge the work of my co-author, Zoe Torrey, as well as some of the other staff who are on this call for your wonderful help in putting this paper together. We hope that it will be useful to people to sort of hold up some examples that have already taken place and to hold up also that funding for whole health interventions is important. Next slide, please. So our first speaker today will be Jennifer Haddad Bell, who's a program consultant at Futures Without Violence. She was involved in development of an innovative treatment paradigm for interpartner violence for victims with depression and pain. And she's gone on to further work with help to domestic violence, to help domestic violence victims. Next. And after her presentation, we'll take questions and hear from our second speaker, Dr. Juan Prandoni, who's the training director at El Futuro Health Clinic in North Carolina. And he'll be talking about research he's done on how to best foster activation among Latino parents of children with mental health needs, and about other research that he's done since. My colleague Ben Anderson, who leads Families USA's efforts to improve maternal and child health, will also be joining us to help think through Medicaid and public health improvements that we can all be asking for as advocates to make these successful interventions more widespread. Jennifer, please go ahead. Next slide. We could go to the next slide and we'll go to Jennifer's presentation. Where did Jennifer's presentation go?
It's at the end of the PowerPoint. I'll just share that.
Okay.
Yes.
I can start talking while you're making that swap, if that's okay. And I apologize. I've been sick, so I'm still got that lingering congestion. So I apologize. But thank you so much for having me. I wanted to share a little bit about the work that I've been doing for almost the last decade. I think it paints a nice picture in terms of how this work has evolved and how you all can start to engage in some of these best practices that I'm going to be talking about. And I have the privilege of having some really great opportunities in terms of my experience across this landscape. I first actually started working in the healthcare setting, and we were integrating pretty early on, before it was something that was a routine practice, integrating routine trauma-sensitive assessment and response for intimate partner violence, specifically in family planning and sexual and reproductive health settings. And there we got funding from Blue Shield of California Foundation to develop a very effective partnership model with a pretty large DV program in our area. And this was happening in Los Angeles County, in southern part of Los Angeles. We actually created shelter-based education, a full shelter-based education program, and cross-training opportunities for the staff. And we streamlined a very effective, expedited process to create bidirectional referrals to directly link survivors into healthcare, specifically to access that preventative women's healthcare and contraceptives and preconception care, those types of things. And then also, as patients disclosed in the clinic, be able to link them pretty quickly and easily into DV support services. From there, I was able to transition to my work with Futures Without Violence, where we were actually the training and TA provider for this project happening in California, across the state, again, funded by Blue Shield of California Foundation, where programs were developing partnerships, again, across the state, very diverse models because the state varies so much geographically and in terms of the types of communities that are being served. And it was all centered around improving the healthcare response to intimate partner violence, and also introducing and expanding health advocacy within DV programs, which is something that was kind of new at the time, and also supporting policy and practice development and exploring data tracking around all of this so we can really look at the effectiveness and look at kind of like closing the loop on the data as we were supporting survivors through these programs. And lastly, I also get to work with Los Angeles County, and LA County is involved in a really fabulous project right now to change the systems here within the county. There is a group of DV programs that has partnered with the LA County Department of Public Health and the Department of Health Services to create countywide policy change and practice change. And if you know anything about the county system, you know, a lot of these protocols have been in place for a very long time, and it takes a lot of work and a lot of time to move these protocols and these practices. But there's a really great group here in LA doing that work. And we've been working to create a network of service providers, helping them to connect with each other to develop partnerships, and also fostering opportunities for further learning around this work. We put on a really fabulous symposium each year called Beyond Silos. And in the next calendar year, one of the things that they're going to be doing is a pilot with 3 to 5 DV programs of different sizes around Medi-Cal access for survivors to really figure out what those barriers are and how we can move past that. You can go to the next slide. So as you can see, I know I gave you kind of a broad background, but as you can see, all of this work is really centered around IPV, specifically at the intersection of health and IPV through partnerships and cross-sector collaboration. And we all know that IPV is extremely prevalent, you know, being underreported. We tend to say 1 in 4 women. I'm not talking about other genders at this point, but just 1 in 4 women alone will experience domestic violence in their lifetime. And we've also seen a pretty high increase of DV since the pandemic. And we've seen an increase in the need for support services since the pandemic as well. So we know that DV is it's a national and very costly public health issue. And we want to treat it as such. And it's also a social determinant of health that oftentimes kind of gets overlooked. And when I say that, I mean, perhaps it's not included in social determinants assessments and things like that. It's not really thought of like one of the core social determinants, but we know that it actually is a really important social determinant to look at and to factor into access to services and supports. And we know that the health impacts of DV are very well documented across research and have been for quite some time, specifically around general health, sexual and reproductive health, also pregnancy and birth outcomes, mental and behavioral health, of course, and just overall outcomes for both adults and children. And I mean, the need is so clear for this work to happen. And again, with the pandemic, the need and the importance of this work to happen became that much more apparent and that much more needed, really. And the pandemic really brought up a lot of lessons learned around how this work can play a role. So a lot of times people tend to get really excited when we talk about partnership work and cross-sector collaboration, but then they tend to freeze because they're not quite sure how to get started. What's the first step? How do you do this with the staff you have and the funding you have? There's a lot of questions that come up. So I like to think of it as sort of, there's like a spectrum to partnership work, and any movement you can make along the spectrum makes a difference. Obviously, if you could do it all, that's optimal, but no program really can do it all. So I thought it would be helpful to lift up some of the most fundamental pieces to starting partnership development across DV programs and healthcare organizations. You know, we've been doing this work for a long time. It's been going on for decades, way before I started doing this work, of course, and it's still a brand new concept for so many people. So I want to try to simplify this as much as possible. There is a lot of opportunity here for advocates and for healthcare providers to help reduce those silos that we see in the care systems and build truly collaborative services across the network of care that survivors are accessing. And through partnerships, we can really leverage our collective capacity to expand support and access and provide a framework for whole person care for survivors. So we can go to the next slide. So this is sort of like, in its simplest form, some best practices or core strategies that folks can take. I'm speaking to the lens of advocates, because I believe that's primarily the audience here is advocates, but I'm also speaking to any healthcare providers or mental health providers that might be on the call as well. All of this translates across fields. You know, the first thing you want to do is find the healthcare providers in your area. You know, that's the first step. A lot of people are not even aware that they have providers like walking distance from their programs. So we want to get to know them, and it's as simple as picking up the phone and calling them, walking through the doors, meeting them, finding out who the decision makers are, finding out who their champions are for DV, if that's one of their pieces of their ongoing services, or perhaps one of their priorities, or if it's a, you know, a common service that they're a common community that they're serving. And you want to think about what is a communication structure that's going to work well. Healthcare providers are very inundated, especially now. It's really hard to add anything else on their plate since the pandemic. So we want to be realistic about what that communication structure looks like. How often are you talking, and how are you communicating so that you can move forward? Next, it's really, really important that there's an MOU, a memorandum of understanding, and that it's actually formalized. The agreement between the organization is clearly defined and formalized, where folks can clarify the goals of the partnership and the roles of the partnership that both organizations will take, and identify the survivor-centered care and response that will happen across the organizations, and establish written procedures for a coordinated system of care between the two organizations. From that, really what would be developed is a system for bi-directional referrals, where the providers can be making warm referrals to somebody that they know, they trust, they've met, they've talked to, perhaps they've actually cross-trained each other. It's so different than just, you know, handing a patient or a survivor, you know, a random referral sheet, you know, where you don't know who you're sending them to, who they're going to talk to when they actually call. And we know the survivors don't really do that type of follow-up on their own. So we want to support them as best as possible. Maybe it's calling right there with you, you know, thinking of those simple ways to work through the barriers to ensure that they get the access that they need, and that it truly is a warm referral where you know they're actually accessing the supports and the healthcare that they need. Excuse me, when I talk about bidirectional referrals, I am talking about, again, both partners creating a system. So patients that are identified as experiencing domestic violence in the healthcare setting are linked directly over to DV support services. And then survivors being served in advocacy settings, they have their health needs identified and they're being linked directly into the type of healthcare that they need pretty quickly and easily, because there can be a lot of, there could be wait times and things like that. And we want to make it as simple as possible for them. And then I know that I'm mainly talking to advocates. With healthcare providers, we tend to emphasize the conversation around routine assessment for IPV and universal education in the healthcare setting. And for advocates, what that really could look like is working towards embedding health advocacy into ongoing DV support services. And this is anything that will help to identify a survivor's health needs and then respond to those needs through making those warm handoffs to the health partner. So, some examples of health advocacy, again, that could be its own spectrum of services that could be implemented, but implementing a routine health assessment as part of the intake process when clients enter into services doesn't need to happen on the first day. Of course, most people do it within the first 2 weeks that somebody new starts. And it's important that that health assessment is pretty well-rounded and addressing as many areas of their health as possible, including sexual and reproductive health, mental health, substance use disorder, medication, access to medications that they may need, vaccinations for their children. I mean, there's a lot that we can think about. And Futures Without Violence does have examples of a health assessment that is available that you all could adopt and adapt for your programs. It could also look like some level of co-location where an advocate is placed in the health setting, or maybe we have a nurse or a health educator or medical assistant placed within the advocacy setting. Shelter-based health education is another example of what this might look like, and also shelter-based clinical services. There are quite a few DV programs that do have a nurse on hand maybe once a week, or they have a mobile mobile medical unit that comes to the programs to be able to make health services super accessible right there within the programs. And then lastly is training. This is really, really important. This is the only way to nurture longevity in this work. Staff need to, obviously they need to be trained initially upfront about the partnership, the services of the partner, the referral system, the importance of this work, the connection between health and DV, so they can really be enrolled in the value of this and why this is so important to begin with. But the training has to be ongoing as the partnership unfolds, as clients are being served and data is being tracked, and you're kind of doing that quality assurance along the way, and you need to make tweaks so that it works better, those types of things. And nobody learns it all in one training, right? It's got to be an ongoing conversation. And luckily, I mean, I can only speak for here in California, but a lot of health programs have a requirement to do at least one training on DV a year. So that's a great start, but we need a lot more than that. So just a starting point to think about. You can actually move to the next slide. All of this is super doable and feasible. There's programs all around the country really that are engaging in some level of partnership work. They are possible, but they do take a lot of time initially to build out. You do need champions to lead the work and keep it going. It does take some funding in the beginning. You need to have the resources and the people power to do it and to maintain it. But once it's in place, it's pretty effortless, and it makes a huge difference for survivors. It also makes a huge difference for the service providers, because there's limitations to your scope. And there's only so much that you can do, and we're not the experts in everything. So if you have trusted partners you can lean on, you're able to extend that care out to the people that you're serving without you personally having to do it. And they learn that your doors are open and you are a place of support. So it could be really, really powerful. I just gave you a whole lot of information in a very, very short period of time. So I want to leave you with some really valuable resources where you can dive into some of this information and these concepts and strategies a whole lot more than what we're doing in this conversation. The first two resources here are online toolkits you can just kind of play around with, and there's actual funnels, like if you're an advocate or a healthcare provider, you can just follow those pages to get the specific information. There's also a page there that highlights the DV healthcare partnership work that was funded by Blue Shield of California Foundation. Futures Without Violence is the home to the National Health Resource Center on DV, so the link is there. That's where you have access to tons of training materials, resources, patient ed, safety cards, posters, toolkits, I mean, whatever you need. And those are all free resources. If it's print, you just pay for shipping. There's also a brief that we worked on that's recommendations for advocates specifically around survivor-centered care and all the lessons learned from the pandemic. And then CUES is our universal education framework. If you're not familiar with that, it would be really powerful to learn about that. So that's a infographic that walks through the steps of what universal education is, how you do that evidence-based practice within your setting. And then I've also provided a link for training videos, because that's also a really great way to kind of absorb a lot of this information. So I know that was a whole lot, but I hope that that it's helpful, and then you can kind of see your program fitting in somewhere along this spectrum.
That was really helpful. Thank you so much. So now's the time that you can ask questions for Jennifer. You're welcome to ask them in Q&A or raise your hand. And while you're getting questions up in the chat, I'd like to just invite my colleague Ben Anderson to make any comments you want to about how to, and Jennifer both, about how do you get these kinds of interventions statewide and into Medicaid programs and into public health programs. So Jennifer, do you want to start with that question?
Yeah, I mean, at the organizational level, it really just takes the decision makers and the champions to start moving it forward, and that having that formalized MOU. There's a lot of programs that have been able to acquire new funding to support this work, and other programs have actually leveraged their existing funding to cover things that they're already doing around this work, or they add in elements of health advocacy, for example, and leverage the current funding that they have. And then, big P policy is like a whole other conversation, but there's a lot of players right now, working on changing, the bigger policy, countywide, statewide, national policy around all of this, so that it is more streamlined. Getting more training for healthcare providers is a big one. Medicaid and Medi-Cal is another area where there's a lot of push and interest and recommendations right now that are happening. Unless things are built into these systems, it's not going to happen. From one perspective, if we think about the healthcare setting and we want providers to do routine assessment for IPV, if they don't know that they can bill for something like that, it's probably not going to happen routinely. And same thing on the advocacy side. So thinking about ways that there could be payment for this work. That's a lot of programs, frankly, are doing it and not being paid for it. So thinking about ways to create more sustainability that way is really important. I can talk a little bit more about Medicaid and Medi-Cal as well, if that's something that you want to discuss. But you tell me where you want to go.
It sounds like that's a good tip, is to find out, first of all, whether your state is allowing Medicaid providers to bill for IPV screening. That sounds like a good first step. Ben, do you want to add anything?
No, I think that really, is the right place to start. And then the other thing that I think keep in mind is different states will treat different populations within Medicaid differently. So you may have some members who are qualifying for IPV screening because they're part of the Medicaid expansion population. But there are also, family planning benefits, and Jennifer, you can speak to the importance of pairing this work with family planning work. There are family planning Medicaid services available to women who lose coverage during the postpartum period, lose coverage for any sort of like red tape reason, like not being home to be able to check, a piece of mail. Or they're also available to women at higher income levels. So that's where we see, I think, some of the biggest gaps. And so I think, as advocates are exploring these issues in their own states, it's important, to look at, is IPV screening available for everyone in traditional Medicaid, expansion Medicaid, and family planning Medicaid?
Yeah, the screening and assessment is a really important first step, but it's really hard to do the assessment if there's no response in place and no support networks in place to have to provide to patients, if they do share experiences of violence. They might not even share, but that it's needed. And that's another big gap of Medicaid. I'm more familiar, I'm in California, so I'm more familiar with Medi-Cal and, very state to state. But I think it's safe to say that a lot of these types of gaps and barriers are probably universal across the state. Maybe California has, even more coverage than other states, so maybe it's not as prevalent. I can't really speak to every state, but we know that the patients under Medicaid, they're very, very low income, and they're dealing with so many other issues on top of the violence and abuse, and then the health impacts of the violence and abuse. They're dealing with some of the core, if we can think of it as the social determinants: housing, employment, transportation, childcare, community safety, all those types of things. And they need support in all those areas. And that's, that's really the support of the whole person, right? And it's hard to isolate and only provide one type of care. And this is one of the, again, one of the pushes and one of the big recommendations with Medicaid is to change that and create a real care network for survivors where folks can be getting paid to do that care coordination to all these other types of services, so that they do have access and they have support navigating it, right? Because that's a huge barrier alone, is the navigation piece. So that's a huge thing to think about, specifically for whatever state everyone is in. We also know that there's provider shortages, which has probably exacerbated over the course of the pandemic. And I know here in California, there's actually been a lot of DV programs that have tried to become a Medi-Cal provider themselves. And that's a barrier because there's tons of paperwork. It's so time intensive. You need whole staff people to be able to make that happen and manage it. And a lot of people start the process and don't really continue because it's not feasible. They also need, there's requirements around the type of licensure that needs to be staffed there in order to do the billing and all that. So there's a lot of barriers. It's not very accessible for programs, but this is definitely one way to change the bigger systems around it. And again, all of this links back to the importance and the value of moving beyond these very outdated silos that we see across the care networks, and have an intentional effort around creating integrated care for survivors, really for all people, but we're talking specifically about survivors, to streamline the access.
Thank you very much. Those are all good lessons for us to keep in mind, and I'm sure we and many of the people in the audience will be back in touch with you to get your technical assistance later as people work through these issues. So thank you so much for joining us. And now I think we'll go on and move to Dr. Juan Prandoni's presentation. So let's switch slides for just a minute, and while we're switching, feel free to continue the conversation.
Thank you. Hopefully you all can hear me and see my slides. Thank you all for having me. My name is Juan Prandoni, as I was introduced earlier. I'm a clinical psychologist by training, and I provide some direct therapy services in our community mental health clinic at El Futuro, where we provide exclusively bilingual services. My other role is as training director with our program La Mesita, which we'll get into here in a little bit. But what I'm hoping to cover today is to give you a glimpse of the work that we've been doing. I should say we're based in North Carolina, in Durham, where our context of the Latino population is an emerging immigrant context, different to probably what Jennifer encounters over in California, where it's more second, third generation. And those things present their own challenges. And I'll talk a little bit about how we've tried to address that both in terms of our clinical care and in terms of the work with La Mesita. But first, I wanted to dive into this PCori intervention, a PCori-funded intervention that we developed in partnership with the University of North Carolina at Greensboro and at Chapel Hill. And Padres Effectivos, or effective parents, is the translation, was this presentation, as I mentioned, that was funded by PCori. We adapted a treatment that was developed originally to help develop the advocacy skills of parents who have kids in mental health. Originally it was for an African-American population, and it was adapted for the Latino community in an iterative process using a community-based participatory research approach. And the intervention focuses on improving Latina caregivers' skills in terms of navigating U.S. systems, in terms of particularly focusing on educational, medical, and psychological services, understanding their own rights. So there's quite a bit of psychoeducation that goes on around these issues, giving them some strategies for problem solving whenever there are barriers, as there often are, unfortunately, for this community in receiving these services. And then working on some specific therapeutic approaches in terms of building communication skills, first to speaking with their kids to figure out what the issue is, so that then the parent can use similar communication skills with providers and with service providers out there to advocate for whatever their kids' needs are. And so we initially conducted a randomized control trial testing this parents that went through this activation intervention versus those that just had a control group where parents just got together and talked without any specific direction. And so I'll talk a little bit about the results from that, and then later how we took this intervention, which proved to be very helpful, and disseminated it into our community here in North Carolina. So what does Padres Effectivos look like? It's 4 weekly 1-hour discussion group sessions. We provided food and tried to be equitable in how we recruited and provided childcare. Also, we had some interns in a separate room taking care of kids if parents had to come with kids. And really trying to keep it short and sweet, knowing that folks have a lot of demands on their time. And so we wanted to be able to cater to that. The groups range from 5 to 8 parents or so. I think my first one was with like 12 parents. I helped run these during the RCT, and then later on in the community, I trained other service providers to deliver this intervention. They were conducted in Spanish, and the interventions had a mix of role plays, homework, and a big part of what helped here was the parent-to-parent support. And this is really just the benefit of group therapy in general, where yes, the intervention and what we're able to teach people is really valuable. And at the same time, seeing other folks who reflect your reality, who look like you, sound like you, have the same experiences as you can validate your experience, and then can also give you valuable insights and advice for how to manage those things. And I think a combination of both of those things, the intervention and the group support, the peer support, is what made this intervention particularly helpful. And at the end, it does also bring in this relaxation technique, just trying to also encourage a little bit of self-care for these parents that often are working themselves to the bone in terms of their jobs, but then also everything they do for their kids and their families as well. So the intervention teaches this main activation skill called Me Pepa, which is short for Me Preparo, or I prepare myself to have an effective conversation. And this is something that we highlighted at each of the sessions, and it tells parents to kind of use this systematic acronym to think through their conversations with their kids, with providers, and with school personnel. And so first we get them to develop a goal. What do you want to get out of this conversation? What are the questions that flow out of that? And then when you ask these questions, give the explain, give the context to your question. Also listen openly, don't be closed off to what you want to hear, and then make sure you understand. And then don't stop there. If you have any doubts or you have anything that remains unanswered, make sure you preguntar para aclarar, you ask clarifying questions. So that idea of persistence, because sometimes parents, it can be difficult for these parents to even start the conversation and ask these questions. And then they might ask a quick question and say, okay, thank you so much. Thank you. The personalismo, the simpatía, cultural values come in here. And we say, no, you have a right as a parent. Your kids have rights. And if no one's going to advocate for them, if you're not going to advocate for them, no one will. And so this last step is really key in terms of getting them to persist until they've got all their questions answered. And they know what the next steps are. So in terms of the results, this is a quick overview of where folks were at baseline in terms of activation scores are here on the left. The patient activation measure is a validated measure for this concept. And so you see that both the control group and the intervention group saw increases in activation. And there you see in the control group where parents were just talking to one another about different issues without any direction, that still was quite supportive and helped them to feel more activated. But we do see a sharper increase and an overall higher level of patient activation by virtue of participating in this group where folks learned the activation technique. And so then once the RCT was proven to be significantly improving parents' ability to advocate for their kids, we at El Futuro went on to disseminate it in different entities in the community, interfacing with schools, also churches and Hispanic resource centers and other community resources. And we were able to disseminate it to all these folks in a relatively short amount of time. Again, this was through PCori funding as well. So that gives us an example of some of the work that we've done where we've tried to both develop and implement and then disseminate interventions in the community. But I want to also talk a little bit now about the direct patient work that we do with clients. And this is more my wheelhouse of what I do in terms of our work with La Mesita, or the little table. So El Futuro, we provide clinical services that are fully bilingual. All of our staff across therapists, case management, and psychiatry are bilingual. And we're really kind of the only game in town in Durham that does this, that offers this. And so the demand that we have is huge. We can't even manage it here in Durham. And then we know that there are folks all across the state that also have some of the same needs that we are trying to cater to here in Durham. So we've developed some other things. Thanks to the pandemic, we went into a hybrid model, and thanks to some of the support we primarily serve a Medicaid population at El Futuro. The ability to do telehealth and receive funding for that, reimbursement for that, has been super helpful, and especially in terms of granting greater accessibility to folks that work long hours and have childcare demands. Some of the telehealth accessibility has been really great in terms of expanding access. We have seen that it doesn't work with everyone equally. I think the opposite ends of the age spectrum, the folks that are higher in age and the folks that are younger, it gets more difficult to engage via telehealth. But in my experience, at least, delivering therapy, even highly manualized treatments, I've found little or no difference in terms of the rapport that I can build with folks through telehealth. And so we're very glad that Medicaid has continued to support that, even as the pandemic supposedly winds down, as we have another surge this winter. We've also reached out to migrant farm workers. We have quite a large migrant farm worker population in North Carolina, as you might imagine. And so we have some programs that beam out into mobile units so that we can provide psychiatric and therapy support to those folks as well. And then La Mesita the idea was that we are able to do all these things through our clinical services in Durham, but we can't reach every client across North Carolina. So what can we do? We can upfit the capacity of other providers in North Carolina to deliver evidence-based, research-based best practices in Latina mental health. So we created La Mesita, or the Little Table, which is our professional provider network, where we set up sort of like a social media site where providers from North Carolina, and indeed outside North Carolina, are welcome to join. We have a space where folks can ask questions, look for referrals, and seek support. And this is born out of what we were hearing from a lot of providers in North Carolina, where often someone who's bilingual might be the only bilingual provider at their agency, or they might be the only bilingual provider for several counties, and the demands on their professional life are pretty high, treating this population with its diverse needs. And so we were seeing that a lot of folks were feeling isolated, getting burned out, and that, as we know, isn't going to help our Latinx population in North Carolina. So we are, through La Mesita, have created a number of continuing education training opportunities for professionals and students out in the community to access these, most of the time free, and except for our big trainings or our conference, really as low cost as we can do to just run things. And these programs are all trying to help providers across North Carolina to engage in culturally responsive mental health care. And as I mentioned this already, I jumped the gun. We've got this provider network. We've got about 1,350 plus providers across North Carolina, and a fair few outside that are part of the network. And this program started about 4 years ago. So we're quite happy and proud of the space that it's filling. Another thing that La Mesita serves to do, which I think the Padres Effectivos intervention is an example of, is bridging the research to practice gap that we see in mental health. So we know that when research findings are established and become best practices, it takes about 20 years from it to go from the academic ivory tower down into the ground, where people are applying these skills and this knowledge on a consistent basis. And a lot of the time that's because providers on the ground either don't have access to academic journals, don't have maybe the tools to synthesize these things into how this knowledge is relevant to their work. So we, through our programming, try to act as the bridge, the conduit, where we take in the research, we bring researchers straight to our providers through our webinars, and we say, hey, can you do a very practical intervention where you take this awesome research that you did, but you just tell folks, what does this tell you about mental health with Latinos and what are best practices, and tell people what they can do so that they leave this webinar and then the next day they can go and implement this stuff. And so we're really trying to shorten that research to practice gap that we see across the board in Latino mental health, or really mental health in general. And so I wanted to cover a little bit of our theoretical approach. Excuse me. So we really try to undergird everything that we do with evidence-based practices. And we use some of these models that look at really trying to get an account for both systemic and individual barriers, and really trying to get folks to understand that these things will play out differently depending on the variability with which Latinos present in our therapy or our treatment offices. So really want to be aware of all of these factors that are coming into play when we're providing mental health. And we also use this model here called MECA, which has these two lenses that really we're wanting folks to not just think about a diagnosis. We want people to think about, yes, people have these diagnoses, mental health diagnoses, but they also want to analyze, what does their family look like? What are the dynamics in the family look like? How is culture, immigration and mental health interfacing, and then also getting an understanding for the migration and acculturation process that folks are going through as they're coming to this country as immigrants. And then ecological context, what does the place they've immigrated into look like? Is it welcoming? Are there resources? Are they limited in the support they can get? So we feel that providing these theoretical outlooks or approaches really helps you to capture the complex and rich diversity of the Latina immigrant experience in order to be able to deliver better mental health services. So just some quick takeaways. This is kind of like a general summary of what we try to say, hope that people come away from our programming with, and hopefully you can all also benefit from hearing this. Probably all already do a lot of this, but it's this idea of, it's good to have some knowledge of Latino values and culture and context, but it's not the most important thing. You really can't know everything. The best thing actually is to just be culturally humble and say, balance whatever knowledge you do have about Latinos, but then be able to ask questions to find out how much that applies to the person in front of you. And then really helping or pushing folks to move away from this deficit model. A lot of the research and intervention research for Latinos has been around what's wrong, what are the barriers, what are the issues with Latinos, and those are good things to be aware of. But we sometimes, by getting to focus on this deficit model, we can move away from this more strength-based model that says, you know, immigrants, despite all the barriers, tend to do well. First-generation immigrants do better than second and third-generation immigrants. So why is that? What is working? What can we build on? What are the positives of Latino culture that we can harness in therapy to make our work more effective? So I know that's a lot and pretty quick, but I'll stop there and open up for questions.
Thank you very much. That was wonderful. And I'm torn between asking you policy questions and asking you about relaxation techniques. It sounds like you have a wealth of experience to bring to the group. So please submit your questions in the chat. And while you're doing that, I just want to ask about implications for Medicaid policy. Have you had luck getting Medicaid to reimburse for your services?
Yeah, so I think I'm not a huge expert on this. I have other folks at El Futuro who are in the weeds about these things. But I know for a while, so we largely serve undocumented folks at our clinic. And in order to be able to do that and make it accessible, we had to fight for a long time with the managed care organizations to negotiate these contracts where we are able to get reimbursement, but they're really not technically, they're providing this money for our services, but it's not, these folks are undocumented. So we're able to negotiate something where we can serve these folks, get reimbursed, be sustainable without the usual requirements for folks that have Medicaid. Now, within that, recently with Medicaid transformation, we've had more difficulty in terms of the changes that have come. We used to have these nice 5 MCOs here that we had negotiated these things, and that's kind of been had to be reworked and renegotiated. And then some of the issues that we've had, in particular, my colleagues shared with me is, for example, we can't really bill for groups in general, because Medicaid reimbursement for group therapy, as I mentioned, which can be particularly helpful for a collectivistic community like the Latino community. The issues is that the reimbursement for groups are not that high from Medicaid. And then also Medicaid counts the group sessions as part of the total allotted number of sessions. So it actually takes away from our capacity to give individual therapy to folks. And then furthermore, my colleagues talk about the Medicaid reimbursement for bilingual and complex supports that we provide to our immigrant community. The reimbursement rates don't take into account the costs and the extra supports and efforts that are needed to provide good services to these folks. So that is something that we're trying to negotiate in terms of higher reimbursement. I think one of my colleagues said we've been able to negotiate it with one MCO, but not any of the others in our area.
Thanks. We are going to want people to stay on for a while, because we would like to just make sure that we get your evaluation of this webinar. And we have one more thing to tell you. But Ben, first, let me go to you to see whether you have comments or questions.
Yeah, no, I think that's great. And I appreciate Dr. Prandoni's insight there, because we know so many of these barriers that he identified are barriers that we also see across the states in terms of difficulties getting reimbursement for group therapy, and difficulties depending on who your patient is and what their immigration status is. One, I think, really interesting thing that's now rolling out in California is coverage of dyadic therapy, and what that will allow providers to do is serve parents, who may not be covered by Medicaid for any number of reasons, but their children are. And it allows for coverage of things sort of in different settings, because we all know, as whole people ourselves, that, our health is intertwined with what's happening in the family. So Dr. Prandoni, I know that, a lot of the spaces where you're providing these interventions aren't necessarily, a pediatric setting, but I'd be curious to hear your thoughts on, whether that's an approach that other providers in other states might be able to take, formulating these groups of parents who may not be able to necessarily qualify for Medicaid, but their children are qualified, and how that might work.
Yeah, I think that's a great initiative, and I'm really glad to hear that that's something that's in place in other places, because I do provide therapy, and we provide therapy across the age range at El Futuro, and it's very rare that we do child therapy and not involve the parents or the entire family unit, even extended family, when we're talking about work with Latinos. So the capacity to be able to also provide services for the parents and involve them in therapy and get reimbursed for that is really great. Even at El Futuro, we've started this new policy of trying to house a family unit within the same therapist. So like, let's say you start with the child, but then comes around through the child therapy and maybe some family sessions that the parent has some pretty severe depression, maybe that's getting in the way of parenting and things like that. We can then bring the parent on for their own individual therapy with the same therapist. And we've found that that's been pretty successful. So any increased accessibility around involving the larger family, I think, can only be beneficial for this community. The other thing I'll mention really quickly is that another main issue that we've had is in getting reimbursement for services delivered by community mental health workers, which is an entity or a provider that we rely on a lot, we partner with. So for something like Effectivos, that's something that's very well tailored for a community mental health worker to do, to deliver. And the community tends to sometimes find more trust or find it easier to trust someone that is in that space rather than a therapist with a higher ed degree or something of that sort. Someone who's a part of the community already has a lot of what's the word? A lot of credit, social credit with the community.
Thank you, everyone. We have a quick survey that we'd like everybody to fill out. So Claire, could you please put that quick survey up? So can you just fill this out? We need to just evaluate this webinar about which areas you work on. Just check all that you apply. Describe your position, check all that apply. Just take a vote, and then we have a couple more questions after you fill that out. Claire, are the responses coming back? Are we ready to go to the next questions? No questions are coming back. Well, then if this isn't working, we'll send this out to attendees afterwards. And then we just have also a quick announcement about our upcoming Health Action Conference. So Nirika, can you share that slide? So we have a Health Action Conference, January 26th to 28th. And there's the registration link to learn about it. We have group discounts available. It's a chance to learn about what advocates across the country are doing. We usually get lots of attendance from community clinics as well. So please visit our website, learn more about it, apply if you're interested in coming. And we would love to see you there. And I just wanna, again, give a big hand to our panelists. We learned so much from both of you. We so appreciate your work. We're honored to have you. Thank you very much.
Thank you.
Okay, bye.
Thank you for having us.
Thank you.